Mindfulness is not necessarily like meditation. It's not necessarily like kumbaya or being like totally detached, as much as it is the psychological ability to create space and to change attention and awareness to different stimuli in your environment, including emotions or sensations or thoughts within your own body.
How to be patient.
Welcome back to How to Be Patient, the podcast where I don't make
where
any
we fly solo, actually.
untimely, where we fly solo. Yeah, we are producerless this week because I had COVID embarrassingly in the big year of 2026.
Mm-hmm. I mean, who among us has not gotten COVID in 2026?
I mean,
Me? Maybe,
most people.
probably. A lot of us, actually.
I'm just like, I'm looking in the viewfinder right now and I like look so pale. Like I look like, I'm like impressed. My skin looks like actually white.
Yeah, it's like
I think it's like a bad lighting thing, but I also think it's like I am truly this pale right now.
I mean, you kind of look ethereal. It's like all the the highlights are coming in. You know, she's for those who are listening on audio, she's levitating actually too while she's.
The leeches have done their job. Just kidding. This podcast does not support leeches. At least
that's right.
not
If you're a
for
leech,
COVID.
stop listening.
Stop. This is an anti-leech podcast. Preston, today we are talking about DBT. But before we get into DBT, I have been inspired by you and Dr. Glaucomflecken and your support of one another and finding humor in healthcare and in DBT. We love to have some levity in the therapy. And so I thought we might talk about, as our opening, instead of talking about DBT and where we need dysregulation, we might talk about people we've been finding funny lately online, especially in the healthcare space. And listeners, I did spring this on Preston like 2 hours ago. So that's my bad.
I consume funny content though. It's easy. You know, it's like it's just like going to the fridge.
I wanted to share these also because I feel like I know we did the episode with Glaucomflecken after you guys had your beef when you were like, Glaucomflecken's not funny anymore. Just kidding. But I will be clipping this part of the podcast from the page. No, but talking about people that you guys both think are funny. And I just thought it would be fun to shout out some people who are like up and coming creators or like just like, I feel like this week in particular, there's just been very good content I've been sending you that is like, this person's like, these are some original people. So I have two to share. And I got permission from them to let me be able to play a bit of their TikToks. Okay, so we are going to roll the clip. We're going to start with my first one. Preston, I don't know if you have seen Abby, but she's the one who talks about the girly swirly whirlies in healthcare. You've probably heard this sound. I'm going to share one of hers. We are mutuals, which I find delightful. And if I can play the audio, I will.
I know you don't want to go to work today, but if it's not you, then who's going to serve evidence-based medicine all while looking gorgeessima? And the girlies deserve that. And the patients deserve that. So we got to get to work.
I recognize this is like not the same thing you're going to find on your stuff, but I like love Abby's. It's just like very much Dr. Divas in healthcare. And like, I feel like being smart in healthcare and also being bubbly still is like not, if you're like bubbly as a woman in healthcare, sometimes it's like, oh, she doesn't know what she's talking about. But it's like, sometimes I want to be bubbly and fun and a diva and also still be serving evidence-based medicine.
Someone has to be gorgeessima.
Someone has to be gorgeessima. So shout out to Abby. I love her content. And she talks about real things as well as an anesthesia resident, but also just as like, here's where you're going to find me on call. And like me on call knows luxury. And I feel like that is the way I cope with being on call sometimes too. So that's my first one. Do you have one you're going to share with the class, Preston?
That's good. Okay, I was worried I was gonna copy you. But the one I really like, this guy Amino. Is he your second?
No.
Okay, so Amino, I don't even know if I know his real name. I sent him an email, but he's
I emailed Amino.
Yeah, he has like 13,000 followers. His profile is just like a picture of a cat. It's kind of like edgy meme type, like Gen Z bio, but he did this series on essentially like practicing so that if I do residency in Atlanta or Montreal or something, like this is how I would act. And so I guess he gives a little bit of a backstory in one of his talking head videos where he said he used to work in the music industry. He was like a producer, I think. And so he was around a lot of hip hop and was like going in and out of the city. So became very well versed in like kind of the cultural vibe of different places. So then he's like, the whole concept is he comes in and he's like, fuck going on with it. As he's like dabbing off the camera and saying like, don't worry, man, we gonna take care of you. And he's just funny. He has great comedic timing. His impressions are really good. I love his accents. And the videos were blowing up. They were, getting like a couple million, I think, or at least, like average of the series was probably like in the 600,000. So people were loving it. And they're saying, like, this is culturally appropriate care. This guy's like he's a medical anthropologist. Like this is what real science is. And then I'll see if we can play some of them, but we might not be able to because he took them down. So I think I went and checked his page today. All of his videos have been, at least related to the residency skits, have been taken down. And I feel like that was kind of just like staring in a mirror a little bit, I guess.
I know I sent you
Yeah.
I was tagging like you and Glaucomflecken. I'm in those comments being like, it's the Father, Son, and the Holy Ghost right now.
God, yeah, dude, it's just a story that repeats itself. So someone felt that they were offensive, and then they reported him to his school, and then his school was like, "Yeah, you're going to take all these down." And I empathize with him because I'm sure he's probably like really excited to see all the attention and how lively it is for people, and they're celebrating this like comedic thing that he created. Like it's exhilarating. It's a wonderful feeling, and then you're also a powerless M1 who ultimately decides your career is more important than these like fun videos you're posting, but it still hurts a lot. So I feel for you, man. We've all been there, or at least I've been there. I don't know how many of us have all been there. And I hope that not a lot of us are there in that position. But I sent him an email. So if he wants to come on the podcast, he's always got an open invite here.
Okay, I have one more. I think he's clocking in as of right now at like 1,900 followers. So like, are we a tastemaker podcast now? Maybe. I don't know. No, this one's a little bit longer, but I just think it was like 20 good jokes, like within a span of 45 seconds. And it reminded me, okay, watching him and then also watching the one you just mentioned, it reminded me of when I first started following like you and Glaucomflecken and was like, now these are some funny, creative people. And so I feel like our listeners will enjoy this. See, this is why you guys should be watching the podcast.
This glass is half empty. This glass is half full. This glass may be half full or half empty. Please correlate clinically, period. This glass doesn't exist anymore. This glass will return. Everyone will return. Hey, sorry to wake you. Did you poop today? Oh, I did med school in Boston, actually. You know the Longwood area? Ever heard of Mass General? Anything else I can do to help today? Glass is unchanged. Medicine to manage. Ortho signing off. Probably not. This glass needs more fluids. This glass is fluid overloaded. How does 115 March 2nd, 2049 sound to you? All right, let's run the list. List? What list?
So I just think Daddyology, wherever you are early in the journey, I can't really pinpoint if he's in pharmacy or med school, but regardless, like just like a rapid take, like, so when you were in your beef with Glaucomflecken era that was fake, but also you were talking about like repetitiveness in terms of content in the healthcare joke space. I just feel like doing different things, but like just like breath of fresh air for all three of these. Like they're doing things that are like creative and interesting and fun and bringing joy, and doing the thing that I feel like you and Glaucomflecken do really well, which is like not punching down. Like everyone gets to be in on the joke.
I could tell he just had fun making that, which I think is like the content I resonate with. Like I could see him laughing to himself as he comes up with the jokes and then like records it around the glass. And I think that's why everyone else thinks this is funny. Like someone who's like genuinely trying to do something that they enjoy. They're not like pandering to an audience because they haven't built up the audience yet. It's just someone doing it for the love of the game. That's what makes me love it.
So if you guys have other people that you think are funny and fresh and original, I don't know that we'll do this again, but we might. And like I don't know. I think it's really special to be able to take our platforms and like share with other people who are doing cool things. We do that already, like when we have people on to talk about their research or their academic work or their other work online. So like, why not share the wealth, and like where there can be joy and humor found in medicine, find it and share it with you guys.
Mm-hmm. Yeah, because there are a lot of tired tropes, but there are fun people doing new things.
Yeah. Okay. So now that we've had our laughs, it's time to talk about emotion regulation and distress tolerance. It's time to talk about DBT 101. And we will do that right when we get back from this break from our sponsors.
If you're anything like me looking for the perfect pairing for your couch, look no further than Cozy Earth's Cuddle Blanket. It is buttery soft, smooth, and just large enough for me and the cats.
And sometimes you're looking for a pairing to really just settle in on your days off onto your couch with that cozy blanket, in which case Cozy Earth also has very beautiful, very comfy matching set pajamas.
Yeah, and my first pajama set ever. So 2026 is off to a good start. The other thing is that there's a 100-night free sleep trial and a 10-year warranty on all of their pajama sets, blankets, and any other product. It's one thing I really like about the company.
Share a little extra love this February and wrap yourself or someone you care about in comfort that truly feels special. Head to cozyearth.com and use our code PATIENT for 20% off. And if you get a post-purchase survey, be sure to mention that you heard about Cozy Earth right here.
Celebrate everyday love with the comfort that makes the little moments count.
So, we are doing a DBT 101 episode because we are lucky enough to have Dr. Kiki Felling on with us in 2 episodes from now. She will be on with us, and she has written a book on DBT. She is an expert. And instead of making her go over 101 information with us, we wanted to save...
We're going to do it now with you.
Exactly. We wanted to save an episode of giving you the one-on-one so we could get into more nuanced takes that might take her expertise as a consult and be able to take our understanding to the next level. And so today we'll be talking about DBT 101. And of course, Preston, the question I'm going to ask you, as I always ask whenever we talk about therapies, what's your experience in residency or med school or just life so far in like interacting or practicing DBT, which is dialectical behavioral therapy for those listening at home?
So I think I've had probably 2 or 3 didactics lectures on DBT with some practice. And then I have not like performed any like focused DBT myself. I refer a lot of my patients to like the DBT groups that we have in our clinic. So I think I'm familiar with it in theory. I know a couple of the worksheets that you can do. I've downloaded and printed off parts of the DBT workbook online. There's like a whole PDF. So I know some sections of it. And that was about it.
Amazing. Do you have to run any groups as part of your residency?
No. All of my therapy is individual.
Got it.
Unless
Okay.
someone wants to bring their partner in, and then I could be a couples therapist.
DBT couples therapy. Honestly, I think that actually does exist. Okay, my background is also not as an expert. I have never practiced DBT in the full fidelity model, which we'll get into what that means. I've co-run groups over a couple years, but like nothing continuous, just like different kind of intro ones. So we are not speaking as experts. I will say I did teach the DBT intro like 6 lectures as part of my chiefship last year as like the therapy chief. So I feel good about leading you guys through this 101, but is why we'll have the expert on for more.
Because you're at like a 201 or 301 level.
I think, yeah. But only a 201 or 301 level, which hoping to learn some more in child and maybe co-run some groups because like adolescent DBT is useful. So I think one thing that we should say is DBT's name, Dialectical Behavioral Therapy. Dialectical meaning, Preston, do you know this one?
So like a dialectic is something that exists on 2 sides, or like it's basically the concept of like nuance
Yeah.
in an academic discussion.
Yeah. So dialectical behavioral therapy comes from this idea. So Marsha Linehan is a creator is the creator of DBT.
It is content. in a way.
It is content. It's just different. It life's content. She's the creator of DBT, and dialectical does, as Preston was saying, mean kind of two opposite things belonging in one. You'll often in the sense of DBT, it's often holding kind of two truths or two stances together, even though they seem to be paradoxical or like they are opposites. It also can be seen in like the yin and yang symbol of like a little bit of everything. The opposite is in something and vice versa. In DBT, so do you have any idea how DBT came to be, Preston? And then I'll stop asking you questions off the top of your head, but I actually am curious because
I think I saw a video of Marsha, not that we're familiar, but she was talking about.
she has passed away. So I
Yeah, this was like from the like 90s, I think.
Oh, wow. Okay.
Yeah, so it was an older video. I think she was just like talking about how it became necessary to find another way to get to patients with personality disorders because supportive psychotherapy would end up ultimately going in circles, but then other like traditional forms of therapy would hit brick walls. So I guess that was like her talking about like the need to start it, but I don't know too much about how she actually went about constructing it.
No, that's exactly right. And one of the things, so at the time, so this is some like 80s-ish, 90s, DBT comes about in the time of psychoanalysis is still somewhat prevalent in the like 50s, 60s, 70s, sort of 80s. And then cognitive behavioral therapy the behaviorists were like really the big theme on the scene, especially for psychologists and non-MD therapists, because in the US, MDs were the only ones who were practicing analysis at that time, despite what Freud wanted, but we will get into that in a separate episode. So Marsha Linehan, for most of the history of DBT and the implementation, the story she told was what you were saying, which is like an academic one and a true one, which is for patients, specifically patients with borderline personality disorder, but other kind of severe emotion dysregulation or distress tolerance concerns, even outside of BPD, things like CBT would maybe be kind of helpful, but then get stuck. Or there'd be a lot of distress and not be able to like continue doing it, right? So like if you're self-harming or suicidal frequently, then it might impede what therapy can do, which is true also for psychoanalysis, but insight-oriented or supportive wouldn't generate change at the pace or in maintaining safety in the way a more structured approach would work. That is the academic version. That was what she talked about for most of her life. At the end of her life, or in the last sort of 5 to 10 years, she actually had her own memoir come out, which is like her story and about creating a life worth living, which people familiar with DBT will know is a phrase that is often part of that therapy, which is that she actually herself had been hospitalized in her youth and had lived the quote unquote emotional hell that she eventually created DBT for, and that the kind of seeds of DBT actually came from her figuring out what worked for her, both within the different placements she'd been in, but also in just figuring out how to try to live her life despite really intense emotional, emptiness, emotional dysregulation, and the desire to harm herself, which in academics and at her level, she did it more towards the end of her career, but is still huge for her to disclose that like this therapy, especially when the diagnosis we're talking about is so stigmatized, which is borderline personality disorder, for her to actually say like, me, this like big, like hugely cited academic psychologist, I have this, and that's how this came, is a big part of the story of how it came to be. I would view it probably as hugely validating for a lot of the people that live under this diagnosis and have benefited from this treatment.
Yeah, it's like a mic drop.
Mm-hmm.
I did this because I figured it out on my own.
Mm-hmm.
Like I know this disorder better than anyone else.
Right.
Yeah. Even now, like I think a lot of psychiatrists are hesitant to disclose their own mental illness.
Mm-hmm.
Even if it's been like what informs you to become a better doctor. And if you look at the specialty breakdown, psychiatrists are more likely to have mental illness than other specialties.
Mm-hmm.
Probably why a lot of them are motivated to go into it in the first place, yet we still feel that wall.
Yeah. Yeah. And I think I definitely think you're right that it's like true in general. I think even more so it's true for things like addiction or for like borderline personality disorder or other personality disorders that do carry so much stigma. I mean, I know you guys want us to do a borderline personality disorder versus like complex PTSD and episodes along that. We will. We're working on it. Consider this our first foray. I'm speaking to the fourth wall right now. We know that you want that. We're working on it. It's the history of DBT is interesting in that it has that unique founder story, I think. DBT is now used not just for borderline personality disorder, it's used for all sorts of people who may need help with emotional distress tolerance, and it's evidence-based for those populations. It can be used in PTSD, anxiety. We'll use it in eating disorder treatment. Ultimately, I think it's somewhat transdiagnostic in terms of it can be helpful for a set of emotional and cognitive like skills and behaviors beyond just the personality disorder category of borderline personality disorder.
And also, I think just life skills. There's a section of it on like interpersonal effectiveness that I've taken to my personal life. Like, I don't know. I have emotions like anyone else. I don't know if I have a disorder of regulating them yet. As I learn about DBT, I'm kind of like, oh, this is pretty good. Actually, I think I'm going to try this for myself. We joke that I think DBT should just be kind of taught to everyone in elementary school as you're learning how to navigate math and reading and writing and drawing, also how to interact with other people with actually good regimented curricula.
A little bit of wise mind just for everyone. Yeah, I mean, I agree. Which that actually segues us nicely into talking about the four kind of main pools of skills or concepts within DBT.
Pillars, if you will.
Pillars. Before I say that, I want to say a little bit about, I mentioned high-fidelity DBT. So high-fidelity DBT, or as Marsha Linehan would call it, DBT, is how DBT has been most studied and practiced. Now, there have been studies around things like just skills training, one-on-one work that are effective, and we won't get into the details on that. But that when we refer to DBT as an effective treatment for borderline personality disorder or like recurrent chronic suicidality or self-harm, most of the time that core literature is referring to high-fidelity DBT.
Sorry, I just keep thinking about the bank Fidelity. You know how that like arenas, like Invesco Arena, it's like, this is DBT brought to you by Fidelity, which is where my mind, I know the high-fidelity DBT is good and it's
DBT
not sponsored by a bank.
Sponsored podcast. Big DBT is sponsoring us.
Yeah, it's like Fidelity sponsored the trials, so now they have to say high-fidelity DBT every time. Okay, sorry, sidebar's over. This is the really good type of DBT that we do all the trials on, and it's not just the little pieces.
Yes. So to throw this back to you, Preston, what is true DBT? What is the format? How is it supposed to be done?
Okay, so it's supposed to be done by like the same therapist in an individual or group environment where you're checking in consistently for, okay, I'm going to get the timeline wrong, but I'm going to guess around like 12 weeks. It's like 12 to 16 weeks. And then the other part of this is that as you're like bought into this therapy, you have essentially a therapist on call so that even when you leave the session and you're having trouble with emotional dysregulation, you're supposed to be practicing your skills and you can call the therapist in crisis to have them kind of walk you through what you're supposed to do or help like reinforce those skills both in and out of the session, which is very different from how it's practiced in a lot of different, like even in hospital settings. I remember in my engineer, someone was like, oh, this person has borderline traits. Let's print out this little worksheet and just like hand it to them on the way out the door. Because DBT is evidence-based for borderline personality disorder. And that might have helped that person, but it's not the whole package.
Yeah. So like if Marsha Linehan's if she's like the Michael Jordan of emotion regulation, it's kind of like, she's like, okay, here's my Michael Jordan, I'm the greatest of all time plan to be really good at basketball for her, be really good at emotion regulation. And what we have, and she's like, and I've studied it and I've applied it and whatever, and it won us these championships, do it this way. And then we're like, what if instead we have them watch 30 minutes of a Bulls games from the 90s? Will that do it? And it's like, No, Michael Jordan just told you what you needed to do, but then insurance is like, we don't want to pay for all that. And so we're not winning the championships to make a
the
horrible
Bulls game
metaphor longer.
It's public domain now. Yeah, I guess what I'm thinking about is we have all this research about how great running is. Like, it turns out that like people on marathon training plans have, better physiques and better mental health and, like increased VO2 max. And it's because they run 40 miles a week and follow this exact training plan and they, do cool down, they focus on their nutrition. We're like, wow, I want to help someone's mental health. So I'm going to tell them to go for a 30-minute jog one time.
Nailed it.
Like right around the block. And then they come back and they're like, I'm tired. And you're like, do you feel better?
Did it fix it? Is that great? And so they're like, I think I have asthma. And you're like, right. Okay. Well, your insurance doesn't cover an inhaler. So yes, no, I think that you're right. And to finish this extremely extended metaphor, it might be better than them doing no running at all, which I think is what we have to think about if we take this extended metaphor back to DBT. Doing some form of DBT or doing some form of these skills, learning or practice outside the high-fidelity model does help. It's just not full DBT, I guess is how we say it. Which I think towards the end of her career, actually, Linehan knew that and knew that it was like not being practiced that way necessarily. What?
It's not true DBT.
It's not true DBT. Well, it's not. Well, and if you think about it, it's like people insurance at true DBT. So you were right in what you were saying mostly. Like it's like individual therapy with a DBT trained and certified like therapist, so who's actually done this model, and then it's the 24/7 available like DBT type of response coaching over the phone. And then there's like the group skills learning part that goes through all of that. It's more than 12 weeks. Usually it's like 3 to 6 months and then you like repeat it, whatever. And then there's a key part of it is the therapists and coaches and the care team meeting very frequently and not like, oh, we'll talk to you on the phone every couple months. Like that meeting where they discharge sort of all of the affect and like what's going on with the patients that they're working with and what's happening in group and individually and in the calls is the other core component of high fidelity DBT. And I don't know if you've ever tried to get...
Can you explain that, the discharging affect?
Yeah. So, I mean, I think one of the reasons that borderline personality disorder is stigmatized is because people struggling with borderline personality disorder, by the definition of the disorder, are doing things that harm themselves or at least struggling with urges to harm themselves, suicidality, the emptiness, and then interpersonal instability. If you are struggling with interpersonal instability, that comes out in the therapy relationship as well. And that interpersonal instability is often things like impulsivity or taking out anger or irritability or no-showing and all that stuff. And so if you really want a therapist to be able to be with a patient who it's constant high acuity and constant interpersonal, maybe like difficulties, basically, then if you want to actually treat clinicians like human and you don't want them to just take that out on the patients and do fucked up shit, basically, like there has to be a place where we're recognizing what's happening in these relationships. Are we actually helping or are we getting sucked into some dynamic that is like not working? And that you don't need to be an analyst to think that. It like can just be like a behavioral group dynamics. How is this all working?
I see. Okay. So this is for the therapists to almost like release the pressure and get their bearings again. Okay.
Yeah.
I can see that'd be very helpful. You don't even think you need to be an expert to know that like things get messy really fast in those types of like high acuity relationships.
Right. And like by definition, the personality disorder diagnosis that we're talking about with this is people who don't necessarily want to, but are struggling with interpersonal like boundaries, self-care, sense of emptiness, hostility, impulsivity, and like reactions of like self-harm or suicide due to like interpersonal rejection. So you can imagine that can be tough to hold alone. I mean, all of us have patients like this, and it doesn't need to be borderline personality disorder. But I think all of us have had patient care situations where someone's really sick. They don't want to be sick, but the way that they're sick maybe is complex because of how psychiatric illnesses make us sick. And so I think of like first episode psychosis even, or like people who have like schizophrenia or bipolar that's not controlled. And like, it's really hard as like a resident or attending, but it's really hard as a clinician to hold that really sick person by yourself and not be like worried all the time.
Mm-hmm.
Or do weird things to try to like make yourself feel better or make them feel better and kind of crash out. And that's like without even getting into like boundary work and like the evils that psychiatry has done. It's just like human to human being. How do you help someone who's really sick?
Yeah, absolutely. Okay. So we're treating both the patients and the therapist because everyone involved is a human. And among the, I guess, the academic parts of this, there are these 4 pillars that we're going to get into.
Yeah. The other thing I just want to say is like this splitting, like whenever we're talking, that's like something that we like throw out there as a defense mechanism. But splitting is something that can happen, again, in the diagnosis as like a defense mechanism for borderline personality disorder, is splitting parts or the good part and the bad part. And so that is also why like the team meetings and also being held by multiple clinicians is important, so that there's less of a continual split that like this clinician is good and this other clinician that I'm seeing who don't talk to each other in a non-DBT model, one is holding all the good and one is holding all the bad, and that's pathological.
Yeah. So for those who are listening that aren't familiar with the term splitting, it's in its essence the inability to engage with the dialectic. So it's hard to hold 2 truths about someone at the same time. So, it becomes very challenging for someone to say like, oh, I'm mad at you, but I still think you're a good person. It's either you're the best person ever or you're terrible. And that is kind of the lens through people with personality disorders can see the world in either like themselves and other people, because they will split on themselves too. But that can lead to these like challenging dynamics. So that at its core is why like dialectic is like introduced in the beginning of it, because it tries to undo that splitting aspect of the personality disorder.
And then as we move into these 4 pillars, the last thing I'll say about dialectic and what Dr. Felling says in her book, that like the core principle or therapist orientation is everyone's trying their best and I need to do something differently or better. But that is like the kind of paradox or 2 seemingly, exclusive truths that we're holding and as the therapists work, and then trying to help the patient internalize when we're doing DBT.
So the therapist starts with the assumption that all the patients are doing their best. And if their improvement needs to be done, it's on my side, the therapist.
Yeah. So the presumption is at the same time. So this is the dialectic. The presumption is that you are truly trying your best and doing the best you can. And we need to improve and do better and try differently.
Okay. I see.
That like both of those things are true, and that even though they appear that they can't both be true at the same time is the dialectic.
Mm-hmm. I see.
Gotcha. So we will take a quick break, and then we will start by talking about mindfulness and emotion distress tolerance, and then we'll do the other 2 as well. Okay, welcome back. Let's talk about the pillars. So we are now in our buckets of both concepts and skills. So the first one that is often introduced in the group settings is mindfulness, which we know and love on this podcast, right? We love mindfulness here.
Do it all the time. I just did it this morning. Mindfully.
I'd be mindful.
I don't mind.
Mindfulness, for those who are interested in it, we've done episodes where we've talked about the concept of mindfulness psychologically. Early season 1, I think, but just as a refresher, mindfulness is not necessarily like meditation. It's not necessarily like kumbaya or being like totally detached, as much as it is the psychological ability to create space and to change attention and awareness to different stimuli in your environment, including emotions or sensations or thoughts within your own body. And mindfulness is a core part of DBT. DBT also is kind of one of its roots per Linehan is Zen Buddhism. And so it does actually carry from there as like part of the inspiration of how do we apply this and use it in a psychological framework we can study. Often the thing that we're talking about with mindfulness and DBT are the what and the how skills. Preston, have you ever heard this? I literally can never remember what these are or how to remember them.
No, I can't think of the what and the how skills.
Okay, so I wrote them down. This is why, because I always forget what they actually are.
Like what am I feeling and how is this coming to be?
So I feel sometimes with DBT that I can't remember this because they aren't actually totally unique concepts from one another, but that's just me being,
Sure.
that's my
So it's hard to
defense
pin it down to DBT.
mechanism. Yeah. Well, no, it's just like, so the what skills are observe, describe, and participate. So they're like what around mindfulness. So observe more closely like what you're doing in the exact present moment, describe it with words to like really focus your attention onto what is happening in the present moment, and then participate. So like an example they give is like, don't try to multitask like while you're on a run, like try to just notice the sensation of running. The how skills are one-minded, non-judgmental, and skillfully. So I think I'm going to get DBT hate for this, but I think I'm valid in feeling like these are not all really truly separate concepts.
Okay. Can we explain the how skills a little bit more? What does one-minded mean?
So the how is like while you're doing the what skills is the adverbs you're trying to sort of do it with. So one-minded means, again, like if you're going for a run, you're not going for a run listening to a podcast and also trying to like, I don't know, take pictures and calculate your heart rate all at once. So one-minded is like the attention is only focused on one component of the experience.
Mm-hmm.
The non-judgmental, I think, is distinct in that it's like while you're doing it, you're trying to turn down this voice that's like narrating how you're doing it. So instead of like speaking into a podcast mic and speaking and also at the same time having the critical voice be like, you should intonate your voice differently and you should be doing this and like, oh, you're rambling and da 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 da. Turning that voice off would be the non-judgmentally.
Taking away the shoulds and the coulds and making them all is and ours.
Yes. Yeah, exactly.
I am doing this, but not I should be doing anything.
Mm-hmm, mm-hmm.
Okay.
And then the skillfully is like a core part of all of DBT. And I don't have a problem with the skillfully as part of the how words, which is just like, is this functioning? Like, is this pragmatic towards what I'm doing?
Mm-hmm.
And so it's hard for me to think of an example in terms of like this specific part of being mindful, but like maybe if it's like you are trying to be mindful to how angry you are in traffic and it's just making you get more and more angry, it's not particularly skillful to be mindful to that.
I see. Okay. It's paying attention to when you should focus on the alarm or not. I guess as you're describing these like what and how skills, I'm thinking of like instruments in a cockpit. Whereas maybe a lot of us can be, we're flying and we're not knowing where to steer, but things like our altitude and our airspeed and like the cabin pressure, stuff like our emotions, we may be less aware of. But then, if the plane's crashing, I'm not going to be like maybe focusing on certain things like the temperature in the bathroom right now or the like whatever else is happening. I have a couple different maybe monitors or instruments that I'm focusing on.
Mm-hmm. Yeah. 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 The other part of mindfulness is what DBT is often one of the common things that if you've probably heard of associated with DBT, which is wise mind.
Mm-hmm.
You're nodding. How would you describe what wise mind is?
So I think wise mind comes. This was in my lectures, which is why I'm like drawing back to it, and I recall it. I think wise mind is the idea of recalling or using your mind to replay your values and ultimately what you hope to accomplish, what you want to get done, and then finding a way to reframe your emotions with your ultimate like wise mind goal. And I think this is, you could correct me for taking a Freudian route here. You're correcting me?
I'm already going to, yeah. What was your Freudian route though? I'm curious.
Oh, I guess I was going to say it's like almost like your super ego. So it's your way to navigate between your id and your ego.
Yeah. So I'm going to correct you. So wise mind is like the combination of like rational and emotional mind. So a lot of people will kind of be like, I don't need to think about how I'm feeling. I just have to do this. Like, I need to be doing this. It doesn't matter if I'm sad or in grief. Like, I need to go on to continue with the running metaphor, I need to do my marathon running training. It doesn't matter. Da, 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 da. an emotion mind, which is like often people then, if you're like doing a DBT group on wise mind, people will be like, well, I can't let my like, and they're in DBT, like let's say specifically for borderline personality disorder. They'll say, well, I can't let my emotion mind win. Like my emotions are the ones that got me here. They're the ones that led me to like self-harm and do like have like suicidal thoughts or like have this relationship go how it did, like, or spend whatever. And so when you're doing wise mind, that'll often be like, I have that sense of almost like a really tight control. Like I have to use my rational mind and my emotion mind is bad. And that kind of like rigidity can lead to staying in this like back and forth or this kind of like roller coaster of being hyper in control and then totally like burning out and being out of control. And what we want is to help people figure out how to integrate the emotional self or the feeling self, the not perfectly quote unquote rational self, and then the like productive, organized, reasonable self. I'm doing a lot of this because I don't actually think these are separated out in this way. And I would say most DBT people
because
don't
both
either.
can be productive. But I guess I'm picturing, the two, I guess like the angel and the demon on your shoulder, and one is like we can only do what is logical. You have to follow this regimen. Like clearly there is no benefit in being emotional, therefore I will not be emotional. See, and the other side is like only emotion. You're like, okay, one or the other, but the dialectic is, or the wise mind is your ability to like combine both of them, because we are emotional beings. There's no denying that. And also when people think about like logically the best thing to do, it's usually driven somewhere at its core by an emotion. It's just like trying to be hidden somewhere. So there's no true only pragmatic self. There's no true only emotional self. Okay. Right. This makes sense.
Yeah. So wise mind, very important topic. So that is a very brief overview of the mindfulness foundation pillar of DBT. The next one that we go to in the book and often in groups is emotion regulation, which is like, everyone, I think a lot of times people hear this and they're like, yeah, I mean, I'd love to regulate my emotions.
That's why I'm here.
That's why I'm here. Yeah, exactly. I think one of the best parts of the emotion regulation that I don't hear people always talk about outside of DBT, that I feel like things in emotion regulation, distress tolerance, like tip skills or other components will get kind of like taken out and put on a worksheet in the hospital outside of the rest of the context. But one of the really, I found, important parts of emotion regulation as a pillar in DBT is understanding and then applying why we have emotions and what their like evolutionary, theoretically at this point in the science, like function is, but also how they're helpful and not the enemy. And if you think back to us just talking about wise mind, there's something in that too, that if we let emotions mean something and be helping us in some ways a lot day to day, then they don't become this thing that we get phobic and rigid and controlling around if they are not just like our enemy.
Mm-hmm.
And so one of the parts of emotion regulation that we won't get into is just like going through and kind of saying like, well, why do we experience sadness? What might be the evolutionary benefit to a human being that experiences sadness to one that doesn't?
I would say it's evolutionarily to help us appreciate movies better.
Okay, now give me your real answer.
If you're sad. Okay, yeah. Anthropologist Preston would say that things like sadness, shame, love, these are all like very pro-community. Mm-hmm. So the ability to mourn someone, even like before and like after they have died, those are things that bring us together. They're very strong, like bonding, mediators of bonding. And I guess sadness also exists as the antithesis of happiness in a lot of ways, which is also very like pro-community. So one of the reasons why Homo sapiens were even able to succeed better than like Neanderthals or other, I guess, Homo subspecies was our ability to have like large groups that worked together in like complex organization. And I think our emotional systems are one of the ways that we are able to do that.
Yeah.
And even things like empathy or like your ability to recognize strong emotions in other people helps you attend to their needs. So not only is sadness a way for you to like mourn someone or be close to someone, it also can be a way for you to signal help to other people. So if I'm sad and I express that sadness, then my community can function a little bit better because people can come to my aid. It's my thought.
No, exactly. I have nothing else to add to that. I think also like I have nothing else to add, but I think helping people like see the use of them, just a lot of people by the time they get to DBT, and I think this is true outside of borderline personality disorder, by the time they see us, period, their emotions have been a problem for them in some way in their life, whether they've been too much or too little or, whatever. And so I think if we can bring ourselves back to neutral and also find some of the good that exists even in challenging to experience emotions, there's like, you're not particularly fucked upness about them then. That's not a clinical term, but there's a sense that like this is our common humanity, which is less isolating than like you are a sad person that is just sad and everyone else doesn't experience it like this. And then it can help people relate differently to the emotions so that there's less of the maybe like quote unquote maladaptive or less skillful responses to emotions that are more desperate or feel like I'm just fucked forever. So like, why would I even try a different pathway?
And I think that also helps promote wise mind because you're teaching someone that your emotions are not just pesky things that need to be suppressed, but important to weave into your identity and concept of self and how you navigate the world.
Exactly. Some things that we won't get into in this part, but stay on for the Patreon part, and we'll maybe do we're going to practice a couple skills together. In emotion regulation is like kind of the basics. Again, a lot of the DBT skills overlap in the pillars, but things like mindfulness of current emotion probably does sound like mindfulness, which is why it's the foundation. But opposite action, love that, girl. Love opposite action. We've talked about that, I think, on the episodes with both Cook with Dr. Brooke and with Amanda. So we won't go into it here. But then like problem solving, accumulate positive emotions in the short term and long term, cope ahead plans. Cope ahead goes platinum every single quarter in my therapy clinic. I love a cope ahead plan. And then please, which is an acronym for some of the emotion regulation skills / things to reduce vulnerability to emotional highs and lows, like getting enough sleep or exercising or eating enough throughout the day, things like that. So lots of skills. We'll get into more of these during our episode with Dr. Fowling. But
so acknowledging both like the psychological and biological aspects of emotions. So this pillar is really, it's normalizing the fact that emotions are there and they're okay. And then let's look into psychologically how we can control our behavior to handle them, but also set ourselves up for success by working on our bodies so that our body's experiencing emotions in a better way. Because I think, I can't imagine trying to do all this stuff while also being hangry and sleep deprived. I think that would just make it way worse.
I'm on call today and you're on call tomorrow. So we have some great time to practice not being regulated.
I'll be doing my please skills tomorrow morning.
I'll be working on them. Pillar 3 is distress tolerance, which again, I think we get to this pillar in groups. People are like, yeah, of course I would love to tolerate distress. And I'm like, girl, I get it. So distress tolerance, if you think of emotion regulation as this pillar that's like understanding your emotions, how they work, and then also like working to make them more workable through a number of things that we just mentioned, right? Distress tolerance is like, well, the really intense, challenging sensation or emotion is here or situation. Now what? And now how do we get through these without blowing up our lives? Like how do we continue to build a life worth living even when these really intense emotional sensations are here?
And so this pillar is more pragmatic.
I would say this pillar is more like we're in distress versus like emotion regulation is like the whole span of things. And this one's kind of like, this is when a lot of the behaviors that people end up seeing us for happen is when they're in this like really intense kind of crag of emotion. And so I think these are the DBT skills that are more of like, how do you get out of this crag without blowing up the mountainside?
These are emergency procedures.
Yeah.
Okay.
Do you know any? Can you guess any that are in distress tolerance?
Well, there's like controlled breathing skills. So that's one. And then there's you can actually you can redirect sensations. So things like ice, I think, are there options. So a lot of people patients already come to this conclusion that if I create a really strong somatic sensation that helps me cope with the emotional distress, but that usually manifests as self-harm.
Mhm.
So a kind of ice is another way to redirect it while still being more adaptive.
Yeah. So you're mentioning a lot of the tip skills, which is one subset within
tips, skill.
this.
Okay.
Yeah.
I think
Other
that's
ones
about all I
in
have.
here are radical acceptance, which I love. Everyone hates me. I also love to use the word willingness, as you guys know. Willing hands is a physical exercise you do that is reminds you, you literally put your hands out when you're in the moment. So these are in the moment skills that we're using, right? Turn the mind, distraction with accepts, which is a bunch of things you can use for distraction. Self-soothe, improve the moment, which are different approaches to make the moment of challenging emotion better, even though you don't get rid of it. And then half smiling, which I just want to end with because I think that's the one that I've never had success. Have you tried hey? You tried just smiling a little bit when you
Wait,
wanna...
that's a real one, half smiling?
Yeah.
That makes me think of that. I think it was a study from the 90s where they said, evidence shows that if you smile, you can make yourself feel happy. Is that
Mm-hmm.
where that comes from? Or the
They're
inspiration for that?
Yeah, they're basically softening your expression. I think they're also in some ways, one of the things that I think when it does work is it is that it's a conscious kind of executive function engagement of some other part of your body rather than just the rumination or spiral that you're in. So I think though, even though it's silly, whether it's true of smiling a little bit, listen, we don't need to love every DBT skill, but even if it's smiling a little bit itself doesn't actually really do anything biologically, I do think there's probably something of I have something I can do. It's something I need to focus my attention away from my current thoughts or emotion experience and focus on trying to smile or open my hands or do whatever and get myself out of the rumination. But
Okay,
yeah, it
I
is
see.
one of the skills. So tomorrow, if you get too many pages at midnight, just remember to smile a little bit.
I will be half smiling tomorrow. Yeah, don't worry.
Be half smizing.
I'll be full smiling. So that's the High-Fidelity call model is Preston doing his tips, please, and high smiling.
Smiling his way through the hospital. Our last pillar is interpersonal effectiveness. Do you remember any of the ones for this?
I do, actually. I know something about this. Okay. So
interpersonally effective a time or two.
Yeah. I've been interpersonally affected as well.
Oh.
So if I remember right, there are kind of three concepts that you have to hold together when you're looking at relationships, which are three values. So you have the value of your own dignity, the value of the relationship that you have with the person, and then the value of whatever this kind of encounter is contended on. So because interpersonal effectiveness ultimately is about navigating conflict with other people, and that conflict comes from competing and sometimes mutually exclusive interests. So the example that comes to mind would be interacting with your landlord. So you have your own dignity, you have your relationship with your landlord, which you can value however much you want, and then you have the cost of rent, which literally has a monetary value. So let's say your landlord is trying to gyp you out of your deposit.
Mm-hmm.
You leave and he's like, oh, I saw there's a dent in the wall over here. So your $1,400 deposit, you don't get it back. How do you navigate that situation? That would be something in interpersonal effectiveness.
Mm-hmm.
So that's kind of all I know. There may be other aspects to it.
Yeah.
That
I think is a core component that is reiterated throughout the skills. There's give, skill, fast, dear man, clarifying goals and priorities. And then I think one I hadn't heard of until I was reading this book was, or I hadn't heard it put as a skill, which is determining level of intensity when asking for something or responding to a request. And there's this interesting, so I have the book right here. So I have Dr. Felling's book here, and then there's the cards that came with it. And I was on consults and we had some like complex situations happening in the hospital that we were consulted on. And so I had brought the cards to work and jokingly was like, let's all pick one and we'll practice in the interpersonal effectiveness skills today. And I had gotten this one and it's like the dimes skill. But it's like this list of 10 questions and it's like every one that is like a yes, then you like should try to go assert yourself. And if it's like a no, then you like shouldn't. And they were fascinating. So that's the skill I want us to practice in the Patreon part. But then Dear Man and other things, I think they're also like it sounds really clunky. I think a lot of things in DBT sound like very clunky and like, okay, that's not going to work for me. But often there's this assumption that we just know how to emotionally regulate or do interpersonal dealings with one another. And like we don't, or we've been taught really ways that get activated that aren't helpful. And I think one of the big strengths, especially about the interpersonal effectiveness components of DBT, is that it actually gives people like a literal script to start with. And is like, how would you even say this? Which I think is part of why people like our podcast is like, we'll do the role playing where it's like, how does this even sound to try to, enact a therapy skill or something, So I think that is a strength of like this part of DBT is it gives scripts.
Yeah, on the intro, it sounds vague and iffy, but when you actually do it, it's a concrete roadmap that you can read off.
Exactly.
That's like where it makes its money.
It's where big DBT. That's where Fidelity DBT.
Yeah, that's where the Fidelity comes in.
Goes to the bank. So those are the 4 pillars. We will have Dr. Felling on to talk about components of this that I think we can give more nuanced clinical situations of like how to apply these. And then if you are on Patreon, you will hear us in a few seconds practicing a couple skills from the book / just seeing if we can use it for while we're both on call this weekend. So we will see you in the Patreon section in just a second.
You can catch the next part of this on Patreon.
It's patreon.com/HowToBePatientPod. We're back. We're in the mainland.
You missed so much in the Patreon section.
Well, thank y'all for coming through this DBT journey with us. This was a good refresher for me. And I'm, maybe selfishly, I get to use this podcast to relearn old topics. But I think it's like the point of why we did this in the first place.
This is the point. We're like, it's
so we got
learning
like kind of learn and chit chat and be like, oh yeah. Like I do have a wise mind somewhere in there. In theory, at least.
In theory.
It's not just all my emotional mind driving.
It's all practice.
If you guys like these shows, like kind of the therapy episodes, let us know. I think we've been having a good balance of them, dipping into politics a little bit too. Everything's political, therapy's political. So I guess at the end of the day, we are a politics podcast. Just despite the categories we put ourselves in. If you want to come chat with us, both Margaret and I monitor the How to Be Patient
spirits
Instagram. Yeah. You can always find me at It's Presro or Margaret at Bad Art every day, or you can go on the website, howtobepatientpod.com, and leave any messages directly. Shout out to all the listeners that are saying nice stuff. Somebody sent an email the other day. Oh my God, I want to find.
Someone asked if we could do an episode on feminist therapy. The answer is yes.
Yeah, I should have had it more ready.
And also the Spotify comments, you will find me lurking there. That is for some reason the place I'm most drawn to respond to people. I'll be like I'll like be making a playlist for my Pilates class that week, and I'll be like, let me just see what How to Be Patient has to say about anything.
It's a unique spot, the Spotify comments, because y'all taught me that you can even comment on Spotify in the first place. Yeah. So comment on Spotify. We'll heart it and reply.
I'll be like, hey girl.
Thanks again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Margaret Duncan, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Our music is by Omer Benzvi. To learn more about our program disclaimer and ethics policy, submission verification, licensing terms, and our HIPAA release terms, go to howtobepatientpod.com or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a human content production. Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.